Unit 4, Nature and Types of Chronic Physical Illnesses. 4.1 Introduction. Chronic physical illnesses like heart-related diseases, diabetes, asthma, and risk factors such as obesity, smoking, physical inactivity, and heavy drinking are all significantly associated with psychological problems. Psychiatric problems in a person suffering from physical illness may result in increased disability, poor recovery, and increased healthcare expenditure compared to those suffering from physical illness alone. In this unit, you will understand the effects and consequences of psychological problems on patients suffering from chronic physical illnesses. Additionally, we will study the association of psychological problems with various specific physical illnesses related to vital organs and systems in the body, such as heart diseases, renal diseases, hormonal and metabolic disorders, oncological cancer disorders, skin disorders, and gastrointestinal disorders. Objectives. After studying this unit, you will be able to understand the association between psychiatric disorders and physical illnesses. Learn about the psychosocial management of these conditions. Point 2. Association between chronic physical illnesses and mental illnesses. The association between chronic physical illnesses and mental illnesses is strong. A history of psychological trauma has been associated with arthritis, joint inflammation and pain, diabetes, increased blood sugar, digestive tract diseases, and cancer. Patients with moderate or severe life-threatening diseases are 3 times more likely to have a psychiatric diagnosis compared to normal healthy individuals. Stressful life events are known to play a role in the onset of hormonal disorders, e.g., Cushing's syndrome. Hormonal disorders may improve with psychiatric treatment. For example, insulin resistance, a factor in diabetes, may decrease after treatment with antidepressants, drugs used to treat depression, and similarly, depressive symptoms improve with thyroid hormone replacement. This association is evident in adolescents and children as well. Adolescents with physical illnesses exhibit more behavioral or emotional problems and are more depressed compared to their healthy peers. 4.3. Nature and Types of Illnesses in Relation to Mental Health. In this section, we will discuss some common and major chronic physical illnesses, along with the psychiatric disorders associated with these diseases. STOS 4.3.1 Heart diseases. Heart-related, cardiovascular illnesses are the leading cause of death in the industrialized world and are increasingly prevalent in developing countries. Coronary artery disease, CAD, is a progressive illness characterized by the occlusion of arteries supplying blood to the heart, leading to cardiac ischemia, which, if not corrected, may result in death. Patients with CAD often present with complaints of shortness of breath and fatigue, which may be mistaken for panic or depressive symptoms, respectively. Psychiatric disorders frequently occur as complications or comorbid conditions in individuals with cardiovascular disease. Treatment of psychiatric disorders improves medication compliance and relieves suffering caused by the psychiatric illness. Some psychiatric disorders associated with heart diseases include 1. Depressive disorder. Approximately 15 to 20% of patients with cardiovascular diseases suffer from depression. Depression occurs in a large portion of patients after an acute myocardial infarction, heart attack. It may independently increase the risk of complications or act in conjunction with factors like smoking or abnormal autonomic function, e.g., abnormal heart rhythm. Depression significantly predicts the quality of life in patients with cardiac illnesses. 2. Anxiety disorder. The risk of coronary events in anxious patients with myocardial infarction increases by 2 to 5 times compared to non-anxious patients with myocardial infarction. Sudden extreme levels of anxiety pose an increased risk of sudden cardiac death. 3. Adjustment disorders. Life-threatening illnesses may lead to adjustment disorders due to issues like dependence on others, loss of control, and anxiety about death. These challenges result in profound disruptions of social roles and the capacity for autonomous functioning. 4.3.2 Renal diseases. Chronic renal failure, CRF, is the end-stage kidney disease and is treated through dialysis or renal transplantation. It has been reported that 23% of patients with end-stage kidney disease have at least one psychiatric disorder. Individuals with renal disease who commit suicide are often accompanied by depression. Some of the psychiatric disorders associated with renal diseases are 1. Depressive disorder. Depressive disorder is the most common psychiatric disorder and is observed in about 17% of CRF patients. Depression significantly increases the chances of suicide in these patients. 2. Adjustment disorders. In the case of end-stage renal disease, adjustment problems often begin at the time of diagnosis. Patients must adapt to a chronic physical illness and their dependence on dialysis to stay alive. Adjustment in cognitive, emotional, and behavioral domains is required by both patients and their families. Denial, as a defense mechanism, is frequently used, leading to poor compliance with treatment. 3. Suicide. Suicidal thoughts are fairly common in patients with CRF undergoing continuous dialysis. 25% of them experience various degrees of suicidal ideation. The suicide risk in patients undergoing dialysis is 15 times higher than that of the general population. High levels of anxiety further increase the suicide risk in depressive patients. 4. Cognitive deficit. Lower performance IQ scores have been noted in patients with CRF before initiating dialysis. However, improvements in short-term memory and attention have been observed after starting maintenance dialysis. 4.3.3 Endocrine and metabolic disorders. Patients suffering from endocrine and metabolic disorders often present with psychiatric symptoms early in the course, while physical symptoms develop later as the disease progresses. Below are some common endocrinological and metabolic disorders. 1. Thyroid disorders. The thyroid gland produces thyroid hormones, triiodothyronine T3 and thyroxine T4. The two most common thyroid disorders are hyperthyroidism, increased thyroid hormone, and hypothyroidism, decreased thyroid hormone, which are frequently associated with psychiatric illnesses. TSH, thyrotropin, produced by the anterior pituitary, promotes the synthesis and release of T3 and T4 from the thyroid gland. Hyperthyroidism presents as nervousness, irritability, fatigue, increased pulse rate, elevated blood pressure, fine tremors, heat intolerance, excessive sweating, increased appetite, weight loss, palpitations, menstrual irregularities in females, and muscle weakness. Hypothyroidism presents as cold intolerance, constipation, menstrual disturbances in females, breathlessness, dizziness, thinning hair, a husky voice, decreased pulse rate, and elevated lipid levels in the blood. Adrenal disorders. The adrenal glands produce steroid hormones which prepare the body to respond to stress. Cushing's syndrome, hypercortisolism, increased steroid hormones, is characterized by moon facies, abdominal obesity, muscle wasting, slow wound healing, easy bruising, thinning skin, and osteoporosis. Cortisol levels are elevated during stress. Adrenocortical insufficiency, decreased steroid hormones, presents with symptoms like weakness, hypoglycemia, low blood glucose levels, nausea, diarrhea, fever, psychotic symptoms, and shock. 3. Diabetes mellitus. Diabetes mellitus is characterized by dysregulation of glucose metabolism in the body. Classic symptoms of type 1 diabetes, early onset, and diabetes, late onset, include polyphagia, increased appetite, polyuria, increased urination, and polydipsia, increased thirst. Other symptoms may include blurred vision, fatigue, weight loss, poor wound healing, dry mouth, and recurrent infections. Most of the morbidity and mortality in diabetes are caused by its long-term complications. Psychiatric disorders associated with endocrine and metabolic diseases. 1. Affective disorders, depression. Hypothyroidism is commonly associated with depressed mood, impaired memory, and concentration, and may result in treatment-resistant depression. Depression in hypothyroid patients is unlikely to resolve until thyroid hormone levels return to normal. Subclinical hypothyroidism doubles the lifetime risk of developing major depression. Symptoms of hyperthyroidism may mimic a manic episode, including nervousness, insomnia, sudden mood changes, irritability, pressured speech, and increased psychomotor activity. In Cushing's syndrome, fatigue and depressed mood are common, especially in female patients. Symptoms like emotional lability, irritability, decreased libido, and anxiety are frequently observed. Social withdrawal may develop due to shame from physical changes. Depression is more common in persons with diabetes than in the general population and is a major factor in hospital admissions and deaths among individuals with diabetes mellitus. 2. Psychosis, a psychotic syndrome known as myxedema madness, characterized by auditory hallucinations, hearing voices, and paranoia, suspiciousness, has been described in hypothyroidism. Severe hyperthyroidism can lead to visual hallucinations, paranoid ideation, and delirium. In cases of acute adrenal insufficiency, such as after the abrupt discontinuation of external steroid administration, psychosis or delirium may develop. The prevalence of diabetes mellitus is reported to be 2 to 3 times higher in schizophrenia patients compared to the general population. 3. Cognitive deficits. Cognitive deficits are observed in hypothyroidism, hyperthyroidism, and hypercortisolism. High cortisol levels are associated with structural abnormalities in the brain, such as reduced hippocampal volume, an area involved in selective attention, learning, and memory. Cortisol impairs attention, resulting in poor discrimination of important information. Approximately 83% of patients experience concentration and memory deficits, with the severity correlating with plasma cortisol levels. 4. Eating disorders. Eating disorders are common in adolescents with diabetes and present challenges in diagnosis and management. These disorders should be considered in patients with poor glucose control or multiple episodes of complications. NAS 4.3.4 Oncological disorders. Cancer is the second most common cause of death after heart disease. Patients express a range of emotions, including fear, sadness, anxiety, and guilt. Over a period of a few days, the level of stress often decreases, but in some cases it persists, requiring evaluation and treatment for psychiatric disorders. The incidence of psychiatric disorders is approximately 50% in cancer patients. Breast cancer remains the most studied, but lung cancer is now receiving the attention it needs. 5 symptoms found in more than 50% of cancer patients include fatigue, worry, sadness, pain, and drowsiness. Other symptoms include insomnia, poor appetite, changes in taste, and decreased concentration. An instrument known as the distress thermometer, National Cancer Control Network, can be used to rate the level of distress, where the patient is asked to rate their level of distress in several domains. Psycho-oncology is the study of the psychological aspects of cancer. Psychiatric disorders in cancer patients. 1. Adjustment disorders. Adjustment disorders with depressed mood, anxious mood, and mixed emotional features are the most common diagnoses in cancer patients. 2. Depressive disorders. In patients with various types of cancer, recurrent thoughts of death are common. However, these may lack the morbid intensity and severity characteristic of clinical depression. The incidence of depressive disorders ranges from 20 to 45%. Depressive disorders may result from a pre-existing condition, the tumor itself, or cancer medications. Carcinoma of the pancreas has been reported to occasionally present with depression as the initial symptom. Despite the high prevalence, depression remains underdiagnosed and undertreated in cancer patients. 3. Anxiety disorders. Anxiety is frequently seen in cancer patients. The cancer diagnosis itself can cause anxiety, as can the drugs used in treatment. Acute stress disorder is the most immediate and shortest lasting type of anxiety disorder, usually lasting less than 30 days. It is associated with intrusive thoughts and avoidance of stimuli leading to anxiety. 4. Delirium. Patients with the delirium present with altered consciousness along with cognitive, perceptual, and behavioral abnormalities. Delirium is observed in 15 to 75% of patients with advanced disease. It can be caused by the primary disease, comorbid physical disorders, or cancer treatment drugs. 5. Insomnia. Insomnia, loss of sleep, is common in cancer patients and may result from comorbid psychiatric disorders or symptoms of the cancer itself, such as pain. Although insomnia is recognized, it is often mistreated, leading to dependence on hypnotic, sleep-inducing drugs, or daytime sedation, which can worsen symptoms of depression and delirium. 6. Sexual dysfunction. Cancer patients often hide their sexual concerns due to embarrassment and shame. Sexual dysfunction is commonly reported in breast cancer patients. Certain treatments can contribute to sexual dysfunction. For example, lymph node dissection in testicular cancer can cause erectile dysfunction, while post-surgical nerve damage in prostate, bladder, or rectal cancers can lead to loss of ejaculation and other sexual impairments. 7. Substance withdrawal syndromes. Nicotine dependence is common in patients with thoracic, head, and neck cancers, putting them at high risk for nicotine withdrawal. Many patients abruptly quit smoking upon diagnosis, leading to severe anxiety, dissociative symptoms, or bizarre behaviors. Alcohol abuse is fairly common in cancer patients. Those with a history of alcohol abuse may experience alcohol withdrawal during hospitalization, typically on the second or third day, presenting as anxiety, poor coping, or postoperative delirium. Psychiatric referral is required for managing withdrawal and providing long-term care. 8. Suicide. Suicidal thoughts and wishes are common, but the incidence of actual suicide is only approximately twice that of the general population. Risk factors for suicide include guilt, feelings of being a burden, hopelessness, pain, anxiety, lack of social support, depression, financial problems, and personality disorders. 9. Cancerophobia. Society's negative perception of cancer often makes it an object of excessive fear. Transient cancerophobia may arise in response to a specific event, such as the death of a family member from cancer. Fixed cancerophobia can range from a neurotic symptom to a hypochondriacal fixation, a false, strong belief of having a serious illness, obsession, or somatic delusion. 4.5 Skin disorders. The initiation, progression, and healing of various skin diseases may be influenced by the presence of psychiatric symptoms or stress. 1. Atopic dermatitis, a chronic skin disorder characterized by pruritus itching and inflammation, eczema. Scratching in response to the pruritus can lead to excoriations and infections. 2. Psoriasis, characterized by skin lesions with clear-cut borders, silvery scales, and erythema under the scales. Psoriasis is associated with severe impairment in quality of life, with a substantial negative impact on psychological, vocational, social, and physical functioning. Alopecia areata, a non-scarring hair loss that occurs in patches of typically well-demarcated smooth skin. 4. Urticaria, characterized by circumscribed, raised, pink, usually pruritic lesions of the superficial skin. 5. Acne vulgaris, a common sebaceous gland disease involving a variety of lesions, including scars that typically occur on the face. 6. Primary hyperhidrosis, excessive sweating in response to mental stimuli, typically affecting the palms, soles, and axillae. Psychiatric disorders associated with skin diseases. 1. Stress. Environmental factors such as contact irritants, allergens, hormones, climate, and stress frequently trigger or exacerbate skin diseases. Disease-related stress is mainly due to cosmetic disfigurement and social stigma. Patients with moderate to severe atopic dermatitis are more likely to experience psychiatric problems. Stressful life events often precede the onset and exacerbation of atopic dermatitis. Stress from anticipating others' reactions to psoriasis predicts patient disability more than any other variable. The adverse impact of psoriasis on quality of life can lead to stress, which may trigger more psoriasis. Patients with stress-reactive alopecia areata report more depressive symptoms compared to others. Stress-induced aggravation of acne vulgaris is frequently reported, with itching and acne correlated with recent stressful life events and depressive symptoms. 2. Anxiety disorder. Anxiety may exacerbate atopic dermatitis by eliciting scratching behavior. Excessive worry has a detrimental effect on treatment outcomes in psoriasis. Anxiety symptoms coexist with adult and childhood onset alopecia areata. Acne significantly interferes with social and occupational functioning, with a positive association between the severity of acne, anxiety, and poor self-image. Even mild to moderate acne causes significant psychological distress and body image concerns. Chronic urticaria patients are frequently depressed and anxious. Women are more likely to experience significant psychiatric symptoms. 3. Depressive disorder. In psoriasis, depressive disorders are associated with disease severity, reduced pruritus thresholds, and amplified itch perception. Psychological factors, including perceived health, stigma, and depression, are stronger determinants of disability in psoriasis than disease severity, location, or duration. Many adults with alopecia areata have major depressive disorder. Studies have shown improvement in skin disorders with antidepressant medications. 4. Personality disorders. Schizoid, avoidant, passive-aggressive, and obsessive-compulsive personality disorders have been associated with skin diseases. 5. Other disorders. I. Delusion of parasitosis, a fixed belief that one is infested with living organisms despite the absence of medical evidence. Patients report tactile hallucinations described as crawling, biting, or stinging sensations. Patients frequently present to dermatologists. Delusion of parasitosis is associated with medical disorders such as tuberculosis, syphilis, blood cancer, diabetes mellitus, vitamin B12 deficiency, and liver disease. It may also be a part of psychiatric disorders, including depressive disorder, delusional disorders, and schizophrenia. Psychogenic excoriation, also known as neurotic excoriations, pathological or compulsive skin picking, and dermatotillomania. It is characterized by excessive scratching or picking of normal skin or skin with minor surface irregularities. Excoriative behavior often shows features of compulsivity and impulsivity. Depressive and anxiety disorders are common in patients with psychogenic excoriation. Trichotillomania, a disorder of chronic hair pulling with characteristics of both impulsivity and compulsivity. Common comorbid psychiatric disorders include anxiety, mood, obsessive-compulsive, substance use, and eating disorders. The most frequent personality disorders associated with trichotillomania are histrionic, borderline, and compulsive personality disorders. 4.3.6 Gastrointestinal tract, GI disorders. When the corrosive effect of gastric acid overcomes the mucosal surface of the stomach or intestine, ulceration occurs. Inflammatory bowel disease, IBD, is a term that encompasses ulcerative colitis and Crohn's disease. Both ulcerative colitis and Crohn's disease are severe, potentially life-threatening disorders involving inflammation of intestinal tissues. Studies have found that the presence of psychological disorders in IBD patients is associated with poor self-perceived functional disability, regardless of symptom severity. The chronic, relapsing nature of IBD, the need for debilitating treatments, and its threats to body image, social, and sexual functioning can seriously impair psychological well-being and quality of life. Psychiatric disorders associated with gastrointestinal tract disorders. 1. Stress. Studies have reported a higher prevalence of psychosocial distress in patients with IBD compared to the general population. Even IBD patients in remission have found an association between disease activity and stress. Ulcers frequently develop in the context of major life difficulties or stress. 2. Depression. Recent studies indicate that depression may exacerbate Crohn's disease. Depression in IBD patients is associated with more frequent visits to gastroenterologists and primary care physicians. 3. Personality disorders. Increased vulnerability to stomach ulcers is observed in individuals with high levels of hostility, depression, and low ego strength. As the symptoms of IBD often begin during adolescence, personality structure may influence how individuals adjust to GIT diseases. 4. Substance abuse. Cigarette smoking, heavy drinking, and drug abuse impair mucosal defenses, thereby increasing the propensity for ulcers. Smoking has been shown to increase disease activity in Crohn's disease. 4.4 Psychosocial treatment. The positive impact of psychosocial treatment, relaxation training, stress management, in the rehabilitation of patients with chronic physical diseases is well documented and supported by research. Patients with heart diseases who receive psychosocial treatment experience greater reductions in emotional distress, blood pressure, heart rate, and blood lipid levels compared to control groups. Psychotherapeutic modalities such as crisis intervention, cognitive problem solving, rational emotive therapy, and supportive therapy with educational and psychodynamic focuses have beneficial effects. By working with individual patients or groups, these psychotherapies help lower distress, increase self-esteem and self-image, decrease anxiety, and provide patients with a better sense of control. The first step in initiating psychosocial intervention for medically ill patients is to inform them about 1. The impact of psychosocial variables on their illness. 2. The influence of social support on their health. 3. The effect of stress on their illness. 4.1 Psychotherapies. 3 different types of psychotherapies are discussed below. 1. Brief individual psychotherapy. This therapy focuses on helping patients clarify and normalize their intense, conflicted feelings and on setting and achieving short-term goals, especially those related to their illness. 2. Couple or family interventions. Families should be routinely involved in the treatment of ill or physically dependent patients to improve coping, reinforce communication, and strengthen bonding. 3. Educational and referral interventions. These interventions aim to maximize the patient's and family's mobilization and integration into a network of support. ASH 4.4.2 Behavioral Techniques. Behavioral techniques reduce physiological arousal and enhance the patient's sense of control. These techniques, such as active and passive relaxation, desensitization, and distraction, are useful in various situations, including oncology, to relieve acute and chronic anxiety related to surgery and painful procedures. Cognitive behavioral psychotherapy, or stress reduction practices, such as meditation and yoga, are particularly beneficial for many asthma patients. Relaxation training, habit reversal training, cognitive behavioral techniques, and stress management training provide significant and stable adjunctive treatments for skin diseases. Improvement of alopecia areata has been observed with psychotherapy and relaxation training. Biofeedback-assisted relaxation and cognitive imagery treatments have been shown to reduce acne severity. Role of counselors. Counselors can work with patients, their friends, and families to help them cope with chronic physical illnesses. They employ various strategies to facilitate healing and progress. Patients may be given the following instructions. 1. Accept your illness. 2. Appreciate yourself as you are, with all your problems, limitations, and appearance. 3. Overcome the why me attitude to focus on solving today's problems. 4. Take total responsibility for your health and seek all available help. 5. Become an expert on your illness. Let us sum up. Chronic physical diseases are significantly associated with psychiatric disorders. This association is evident in adolescents and children as well. Mental illnesses increase disability and decrease the quality of life in already compromised individuals. Since mental illness can affect the quality of life in severely ill patients, addressing mental health in patients with chronic illnesses may assist in reducing morbidity, disability, and suicide. There is a need to employ an integrated, multidimensional approach to healthcare. As it is often said, it is time to examine mental and physical health as a combined entity in our public health efforts. 4.6 Glossary. Acute myocardial infarction, heart attack, adrenocortical insufficiency, decreased steroid hormones, coronary artery disease, a progressive illness characterized by occlusion of arteries supplying blood to the heart, leading to cardiac ischemia. Cushing's syndrome, hypercortisolism, increased steroid hormones. Diabetes mellitus, dysregulation of glucose metabolism in the body. Hippocampus, an area in the brain involved in selective attention, learning, and memory. Hyperthyroidism, increased thyroid hormone levels. Hypothyroidism, decreased thyroid hormone levels. Hypoglycemia, low blood glucose levels. Paranoia, suspiciousness. Polyphagia, increased appetite. Polyuria, increased urination. Polydipsia, increased thirst. Psycho-oncology, the study of the psychological aspects of cancer.